First of all, grateful to all of you for inviting me to be a chief guest for this excellent program, scientific program. I think this is one of the best conference I could see, and scientific program is extremely well set to go. And faculty, 100, so many faculty is there. I think more than 100 faculty is there. And that is very good for our conference. And ultimately, as you said, we distribute knowledge. And that's the best thing to do, is to distribute knowledge. And it's a great honor and pleasure to say that the conference is open now for academic deliberation.
Thank you very much, sir. Thank you. So now I invite Dr. Vijay Bang for his oration, which he's consented to be giving. And as I mentioned, the topic is about the present and the future, what we have done, where we stand, and where we are headed for. We are seeing that the cardiology has become extremely dynamic in times to come. Things are changing. Angioplasty is not something that is going to be in vogue forever. Things are going to change much beyond. And that's what I think Dr. Bang should guide us. Dr. Bang, over to you.
It's a great pleasure and honor to deliver a keynote address on emerging and conquered frontiers of interventional cardiology, the path ahead. I will do my best to give this message not only as an interventional cardiologist, but also as a CSI president-elect for this year and chairman of the scientific committee. We all know that interventional cardiology is all about devices, innovation in devices. And it creates a path-changing and game-changing frontiers. We know that in coronary space, catheter intervention has done a remarkable job, saved thousands of lives, particularly through PAMI and ACS interventions. But story is not different for even revascularizing left main lesions in stable coronary artery disease and proximal LAD lesion or equivalent coronary artery disease. Story is the same. There is no difference in that. And it's not only that, it is proved to be extremely game changer in structural heart disease, particularly. Because that space, there was a need for another intervention procedure, which is catheter-based. Because surgeons could not have managed all those cases which are high risk to the surgery. And those are managed by catheter intervention in structural heart disease, particularly TAVI and mitral valve interventions. They have proved to be extremely fruitful, extremely good, and reduce the mortality by 50%. There is no interventional procedures which reduce the mortality by 50%. Now, to start with, I would like to go into history a little bit so that we get to know how to inspire ourselves. Dr. Soames performed, while he was doing the aortogram, inadvertently his catheter got deeply engaged into right coronary artery and patient arrested. He pulled out the catheter and patient was resuscitated after the full CPR, but he didn't get depressed. From there, he realized we can do selective coronary angiography. So he developed Soames catheter and started doing selective angiographies. That's remarkable intelligence of a man. In adversity, he turned out to be a winner. And that is how the overall interventional cardiology process has begun. Because had there been no angiography, interventional cardiology had not begun at all. Then Judkin came in 10 years later, 1967, and developed a pre-shaped Judkin catheter, and they are proving the test of the time even after 50 years. That's a remarkable achievement. Then in 1964, Charles Daughter, interventional radiologist, he thought of doing in femoral artery, he thought of doing sequential larger catheter dilatation and modifying a plaque. And through that, he was very happy. The result was literally better. It was not so acceptable, but it definitely looked better. Nobody was impressed in America with his adventure, but in Europe, Dr. Zettler was impressed, and with him, Grundzig was working. So he inspired from there that he has to do something in this space. So in 1974, he performed first balloon angioplasty in peripheral artery. And that is how the journey has begun. The next thing that he did is he performed intraoperatively in America in 1977, the balloon angioplasty in coronary artery, intraoperative. And then in 77 September, he performed 16 September 77, he performed the first balloon angioplasty in the cath lab. And the result of that angioplasty, you can see it here. And every 10 years, the LED angioplasty, which was done in 77, is checked by angio, and it is patent. And the patient picture is here, if you all can appreciate. The patient picture is here, and this patient is still alive. So it's an amazing journey. And what he did is he developed the balloon catheter in his kitchen. You can see the glass of wine there. You can see the glass of wine there. And then this was his first LED plasty, and we showed a remarkable result. And this patient still survives, and he doesn't require any intervention in the LED at least. He has undergone other intervention of RCA, but not LED. Then that time, after this was his left main was his fourth case, without the surgeon support, no surgical backup. And he performed this balloon angioplasty with this result, and even that patient is doing well till today. So this is amazing, but now we took he did it in 77 or maybe 78, and we took 2009, 2010 to start our process, 2010 to legalize our left main angioplasty. Then Grundzig presented 4 cases in AHA, and not only he's a father of interventional cardiology, but he's also father of the live teaching courses. So what he did is, you can see the amphitheater here, and he invited the interventional cardiologists from all over the world, Europe, America, and all were sitting in the hall, and from the remote cath lab, he performed the angioplasty and taught them how to do angioplasty that time. So he has opened the gate for revolutionized the gate for learning revolutionized the gate for learning. And his concepts were very simple, that he thought it's like footprint in the snow. Doing angioplasty will be like a footprint in the snow. So he did this, and result was good. But 1985 was a disastrous year. All the grandfathers of angioplasty, Dr. Sohns, Dr. Grundzig, Dr. Daughter, and the doctor, all 4 of them expired in the same year. Grundzig expired in a very young age with a plane crash. The interesting part is his balloon. This was the balloon he developed. And you can see there are 2 ports. Through one port, he will inject the dye, and through other port, he will monitor the pressure and also inject the dye. So, and then sequentially, he will do the balloon dilatation. You can see the pressure difference before the block, and this is after the block. Means there is a pressure difference in the distal to the block. And then he did a balloon angioplasty, pressure difference has reduced. Then again, he did until the pressure equalize, distal and proximal pressure equalize. In 1982, Simpson got the idea of putting a wire inside. This was without the wire. Dr. Grundzig did without the wire. Whereas intracoronary wire was developed in 1982 by Simpson, and over the wire balloon was developed, and that increased the number of angioplasty remarkably. in that year, a remarkable number of angioplasty was done. That gave birth to intracoronary imaging, followed by restenosis was identified as the biggest challenge for interventional cardiologists. Then atherectomy devices were developed. Then intracoronary stents. Then restenosis was addressed by drug-eluting stents and brachytherapy. And then PAMI was developed by Hertzler. First PAMI was done by Hertzler. The interesting part, angioscopy was done in 1985. It was intraoperative. Means during the surgery, angioscope was passed, and this was seen by Grundfest. Later, it was taken to the cath lab by Spears in 1988. But 1988, intravascular ultrasound imaging was done, and that's the time they realized that there is under-expanded stent, which Dr. Colombo suggested to optimize it by high-pressure balloon expansion. And that is how Antonio Colombo became very famous. Then in 1990, intracoronary Doppler was done by Hartley by attaching a Doppler at the hub of the Sones catheter. And Doppler, but that was only a academic exercise. But clinical benefit of that came in. Clinical benefit of that came in the 1996, where fractional flow reserve was done. You can see the guiding pressure here, pressure from the guiding catheter, and this is the pressure beyond the block. Initially, the pressure difference is low, but as you give adenosine, the pressure difference is wide because the distal artery pressure with adenosine dropped. And this is how the fractional flow reserve came in the picture. And that time also, the critical looking lesion, FFR was negative, and non-critical looking lesion, FFR was positive. So this is a great history, which has now transformed the area of interventional cardiology in many ways. Restenosis was a bigger challenge. Many therapies were developed at that time. And to address that, that time POBA used to be called as PTCA, but now we call it POBA. So this is a very interesting part, and they have found out that number of angioplasties have gone up, but similarly restenosis rate is also gone up, and they spent $4 billion only managing restenosis. So atherectomy devices came in the picture, directional atherectomy came, but it was not very useful, followed by laser atherectomy came, and then the biggest accomplishment, rotational atherectomy. But that time, rotational atherectomy did not give that good result. Following that, stents were developed, and first peak study was done. And you can see instant neoatherosclerosis in the pig artery. And across the branch, the stent was deployed, and they could note that the flow across the branch is good, even after deploying the stent across the branch. So that is how the angioplasty began. And then it came in human artery, with the daughter doing a first stent in 1969 in a peripheral artery, and Sigvard did in the coronary artery in 1987. Sigvard is a brilliant cardiologist. He's also a first-time doer of the septal ablation in Hocum and supposed to be very good. Then stent was developed, and stent seems to be better than a PTCA. We can see this result, but still the restenosis rate was very high. So we needed some more devices. Brachytherapy was developed, but then that was not enough. Brachytherapy was successful, but that was not enough. So then slowly we evolved to drug-eluting stents, and drug-eluting stents gave excellent result in that, but restenosis remains the challenge. Then developed the thrombolytic therapy. Timigrate was developed, and then Hartley performed first PAMI, and PAMI results were far better. Improvement in LV function was remarkable, and mortality was low in the patients whose PAMI was performed earlier. So that is how Hartley started. And then stenting was better than POBA in PAMI. And PAMI was better than lysis. So this was all everything. And then adjunctive therapy like GP2B3A developed. But most importantly, because of all these advances, there is a remarkable reduction in mortality from 1980 to 2000. 41,745 patients saved the life, and 50% of life saved accounted to interventional cardiology procedures. So path ahead was good, but there were several challenges even with the drug-eluting stent. So bioabsorbable stents had to be developed. Bioabsorbable stents also produce challenges. Thought that it will give good vasomotion, but vasomotion was equal to that of the stent. Even stent had a vasomotion, which is numerically though different, but statistically almost a non-significant difference. So then absorb stent was having a late thrombosis problem. Then drug-eluting stent progressed from first DES to second DES and then BRS. So at the moment we have this second generation stent, we know Resolute and SANS, but Synergy is the third generation stent, which is the only stent which is of the third generation. Then of course FFR revolutionized stable coronary artery disease, and 19 studies suggested that only FFR guided PCI is a superior PCI because it's appropriately indicated. And then the microvascular dysfunction was identified by use of FFR and IMR. And several conditions like INOCA, heart failure, preserved ejection, cardiomyopathy, several conditions are included in 2021 in this space. The intravascular imaging has revolutionized. It provided the morphological detail on cath lab table. We could understand what is the pathology going on. And precision in angioplasty developed with assessment of morphology, followed by sizing, diameter and length of the stent, and then optimization of stent all together, and it produced better result. All the three meta-analysis studies showed that there. Then not only that, the intravascular imaging also, particularly OCT, having a high resolution, gave the good idea about how this dissection, malposition, all other details are identified during the procedure and can be corrected. So there is the result of the procedure is good. There are no complications. Then the scoring was, calcium scoring was done. Calcium is always a challenge, thrombosis and calcium, two biggest challenge for the coronary interventionalist. So many atherectomy devices developed. They have rapidly progressed. And today we know that IVL is also there. So there are multiple atherectomy devices and they are all very useful, but they are adjunctive devices. So, and then because of this, the intravascular imaging and calcium devices and hemodynamic support, even complex cases which were denied surgery due to high ST score, they were also done with this, with a high syntax score more than 32. They were done by PCI. So we know that Impella hemodynamics is better. Then robotic PCI, of course, everyone knows in Gujarat, Ahmedabad, Tejas Patel has made a largest number of series in the world on robotic PCI. And that reduces the radiation tremendously. And now there is a different dimension to it, that is tele-intervention. You can do it from very great distance. Then, of course, renal denervation for resistant hypertension. And it's initially, though it was not successful, later it found to be successful. Then came the paradigm shift to structural heart, remarkable innovation and remarkable benefit to the patient. And the intervention, catheter-based intervention were developed in aortic, mitral, and tricuspid position. Not only that, even left atrial appendage and patent foramen lower were closed to benefit the patient. Now coming to the TAVI, a little detail. The TAVI, we know that once the patient of severe AS becomes symptomatic, the 50% mortality is there in 2 years. So, but surgery reduced this mortality. Surgical AVR reduced this mortality. But there were so many patients who were not fit for surgical AVR due to high ST score, and they were remaining untreated. So there was unmet need, definitely. And that unmet need was provided by none other than Dr. Alain Cribrier, who developed the first aortic valve and deployed it. In 15 minutes, patient was extubated and was smiling. And in soon 7 years, 3 generations of TAVI valves were developed, 9,000 procedures, TAVI procedures were done. And if you see the mortality, all-cause mortality is almost equal to that of the surgery. But the advantage is now today in 2021, it's a day procedure. It's a sedation-based procedure, no anesthesia, no ICU. Just do the procedure, put in the ward, and you can discharge the patient same day or maximum next day. Then there was a issue with the paravalvular leak, which was there with surgical AVR and TAVI both. And they have addressed that issue very well here, and that was reduced, paravalvular leak was reduced. Not only that, the TAVI and medical treatment, when compared, the TAVI produced 50% reduction in mortality. And same way, TAVI and surgical AVR, almost same mortality, but the stroke-wise, remarkable difference, which was statistically significant. And this, over a period of year, 4 RCTs were done and meta-analysis was done. It emphasized that even mortality is better with the TAVI, and stroke rate is also better with the TAVI. So why not do it in low-risk surgical AVR also? So those patients were started doing. 3 trials were done in low-risk patient of TAVI, and all 3 trials were positive. So low-risk trial above the age of 65, we can consider TAVI also, because valve age is same in surgical and TAVI valve, same age. Then paravalvular leak, as I said, is a big issue, and now it is addressed by different intervention, and improvement in the devices has reduced the paravalvular leak incidence remarkably. The projection is in almost 3 lakh procedure will be done per year after 25. So many devices have been developed. They are all US FDA or CE mark, and they are all very good devices. Then paravalvular leak devices were also developed. They are all in use, and they are remarkably benefit to the patient. Then same unmet need was seen in mitral regurgitation cases. Mitral regurgitation was severe, but many patients were not surgical candidate. They're surgically not fit due to high test score, and there the catheter-based intervention was done. And we can see that only 50,000 surgery was done. In fact, incidence is 250,000, and 2 million patients are in prevalence. So doing intervention, catheter-based intervention might help some of these patients from dying. Yeah. And MitraClip picked up that very well, though it's a very difficult valve to intervene. Delivery is difficult, fixation is difficult, sealing is difficult, even function is difficult. So, but MitraClip turned out to be the winner here. And you can see that when you compare MitraClip results with CRT, ICD, and drugs, MitraClip beats everything. Number of hospital admissions have reduced. Mortality is also reduced. But it is used both in America, it is used for degenerative mitral valve disease, and in Europe, it is used for functional mitral valve disease. And then came the era of tricuspid valve intervention. And that is mainly for the organic TR and even for functional TR with the dilated annulus. And in this also there was clip, like a MitraClip, and annuloplasty was also a direct and indirect. And 2 types of valves were developed. One is put on the valve itself, that is called as the orthotopic, and heterotopic, which is in IVC and SVC, what we call a trick valve. And that also produced better result. RV function improved with that. And it is supposed to be excellent innovation and intervention, catheter-based intervention in the space of tricuspid valve. Then came these patients who have this atrial fibrillation and develop stroke. Is debilitating to have a stroke. You can see that T was done on this patient. There was a thrombus in the appendage, and many of these thrombi are dislodged from left atrial appendage. 90% stroke occurred from here. So why not close this in case the patient doesn't tolerate the NOACs or DUACs? Only in this subset of patient, not all patients of atrial fibrillation, you need to do the left atrial appendage closure device. Only in patients who are not able to tolerate NOAC in non-valvular AF. Then came the same indication for patent ductus arteriosus, patent foramen oval, and that device also developed. And initially it was not successful, but now there is, in a selected patient, you can consider this. And this is supposed to be good. Now coming to the future directions. This is a very important space, and we need to cover this very well. And artificial intelligence is something which is going to take over interventional cardiology. It's because it improves the diagnosis through machine learning. ECG, you can artificial intelligence in ECG signals. If artificial intelligence interface, same way in echo, cardiac MRI, and CT, all can improve and redefine the diagnosis of the disease in early stages. So it's a very good, very good artificial use of artificial intelligence, and it's supposed to do wonderful work in this area. Not only that, it can help us maintain the data, it can help us do the procedure from the distance, and even voice mediated command can be given to the patient while the patient being operated. So artificial intelligence has developed remarkably, and it improved if you see isolated surgery and CABG. You can see valve surgery and CABG in both. Monitoring with artificial intelligence devices, it has helped in assessing predicting the outcome, and outcome is better assessed, and you can see that this is remarkably better. Then there will be a breakthrough. Already there is a breakthrough in the congestive heart failure space with the devices. One is sensors. Pulmonary artery will have a sensor which will monitor pulmonary artery pressure and wedge pressure. The LV remodeling devices, contractility modeling devices, microvads, and interarterial shunts. These things are going to develop very fast, and they are already in the scenario, and some of them are in the pilot study stage. Some of them are already approved for commercial use, and they are supposed to produce excellent results. Now coming to, this is a parachute device which is placed in a patient who's got anterior wall MI and developed aneurysm. So this goes perfectly and sits there, doesn't produce any arrhythmias, preserve torsional contraction, restores conical shape of the LV, reduce LV EDP, reduce LV volume, and even partition the scar completely. So this is supposed to improve the hemodynamics in patients with aneurysm, LV aneurysm, or area which is not mobile, a kinetic area of the valve, large area of the left ventricle. Then pulmonary artery pressure can be monitored. If we monitor the pulmonary artery pressure, we can reduce 30% rehospitalization in 6 months. And in fact, in real world, it was 38% reduction in. So just putting a pulmonary artery, monitoring a pulmonary artery, we can titrate the doses of the drugs and improve the condition of the patient. The another heart failure devices is to unload the cardiovascular system with the volume, lymph, and the volume. And that is done through the through the shunts, and also through a transvalvular pump. You can see the pump here. And both these are at the moment investigational, but supposed to work very well. Plus there are wearable devices which will help us monitoring the patients with heart failure, and also the pacemaker, which is called as bursting pacemaker. It can reduce the sympathetic drive and improve the patients with heart failure. Similarly, these are shunt devices. These three are shunt devices, and they are very useful. Now, imaging modality, multimodality imaging, intracardiac echo will come in a big way after diagnosis will be very easy with AI application. And this is going to be a complete revolution in imaging. Not only the interventional OCT AI use has already started. It's called as software. It's called as Ultron 1 software. It helps in detection of the EEL and also the calcium. And it helps in sizing of the length of the lesion and the diameter of the artery. And it can assess, so we can do a morphological assessment first, followed by sizing, and then deployment, review the deployment of the stent, and it can produce very good result. Then calcium scoring will produce also is excellent information that we get from this. Now, not only that, now in future, live cases will become easy with cloud-based service deployed in the cath lab, and it can reach to the classroom, conference room, it can reach to different location, physician's place, recovery room, and we can see that these patients, other people can learn intervention while sitting in the classroom. So, and then at the moment, patient has to go for multidisciplinary consultation for certain procedure like mitral cleave. It requires TAVI. It requires multidisciplinary consultation with the anesthesiologist, cardiac anesthesiologist, cardiac surgeon, the interventional cardiologist, and cardiologist. All four are the part of the team. So they can virtually meet and discuss this case in presence of the patient and can give a good diagnosis. Similarly, tele-intervention, as I said, this is extension of the robotic PCI. Then this is thing which is now commercially available in America. We do angioplasty and we open the epicardial artery. But what happens to the microcirculation? Unless we improve microcirculation, we cannot stop the injury to the myocardium. And reperfusion injury, we all have heard, cause more damage than causing a reperfusion, doing a pump. And there's a device which has come, and this device is supersaturated oxygen delivery device. And this will, through the catheter, after the pump is done, this will be connected to the catheter and directly supersaturated oxygen will be delivered in the LED. It's only done for anterior wall myocardial infarction. So if you do this, you can improve, if you do this, you can improve the endothelial swelling, you can improve coronary blood flow, reduce infarct size, free radicals, and also by doing this, we can reduce infarct size and reduce hospital admission and heart failure. So this is a very important device which will come in the picture. Now there is also a progress in the stent, which is called as bioabsorbable electronic scaffold. It has been tried in Korea, and it has electronic which will read the pressure, the temperatures, and will tell whether patient has developed restenosis or patient is developing thrombus, and that will help in the management of before the patient develops the infarct. So there are some remarkable improvement, and we need to continue and progress. There is no end, and more innovations in interventional cardiology are expected, and it will change the complete scenario. Another most important intervention that is expected is the percutaneous VAD, which I showed macro VAD across the valve, and that may be improved in such a way that there is no need of cardiac transplant. Only deploy that device and it will work like a cardiac transplant. So that is the kind of projection or vision that that is expected to come from all this intervention. And I thank you very much for your kind attention. And I hope that people have understood that there is still a lot to come in interventional cardiology, and it can improve this space. So I tried my best to stick to the time so that I don't give any pressure to the organizer. And I hope it was good for all of us. And let's see.